morning, everybody, and thanks for coming for this session on what's new in pediatric ophthalmology and pediatric cataract. Actually, pediatric cataract management is not as challenging as we used to think before because a lot of advances in technology. But one thing is, as pediatric ophthalmologists, we are very conservative. We would only apply or adapt a procedure in a child which is time-tested and not being very aggressive in just trying out everything which is new in the market. So most of our talks will be like, what new we are doing because of rehabilitation, all that has become much more easier now with technology, good microscope available and different types of intraocular lens. We'll try to briefly, try to give you an idea of what is being done newly in pediatric ophthalmology, but keeping in mind that the longevity of the living years in a child, we should not be very aggressive in choosing the procedure. It is always better to customize what is needed for that child, for that age group, and keeping in mind that, they are the future of the, or the future age group. So we have to keep that in mind. With that, I welcome the first speaker, Dr. Sashikala Elizabeth, who's a consultant in Aravandai Hospital, Coimbatore, with us, and she'll be talking on biometry, pediatric cataracts.
I'm Dr. Sashikala. Good morning, dear teachers and my dear colleagues. I thank the scientific committee for this opportunity, for giving me this chance to stand in front of you to present this. Yeah. So today my part is to cover on biometry and IOL power undercorrection. I have no financial interest. So as pediatric ophthalmologists, it's indeed a big challenge for us to calculate and select an optimum IOL power for the growing eye of a small child. So this is a complicated decision-making process for us. So the accuracy of IOL power calculation, it has not shown a similar amount of improvement which has happened with a surgical technique. And the formulas that we use for the pediatric group are ideally designed for the adult eye. So there are only fewer evidences that are present that tells us the accuracy of the IOL power in these pediatric eyes. Again, compliance to amblyopia therapy is a big question, and a long-term follow-up is required in these children. And children, we know they are less cooperative for in-office measurement, so there is a requirement for us to do an evaluation under anesthesia, which raises a lot of possibilities of errors. Just briefly on the growth of the normal eye. So as the child grows, so from birth as an infant to late childhood, till 13 years of age, there is an increase in the axial length, we know, from 17 to 24 millimeters, and the lens pass starts gradually reducing down from 34.4 to 18. Gordon and Donsel, they had shown that 90% of the growth gets completed in the first 18 months of birth. So what happens after a fixed IOL power is placed in an eye of a child which is growing? So following a cataract surgery, there is loss of natural lens. So there is disturbance in the emmetropization process. So every millimeter axial length grows, there is a 2.5 diopter change in the refractive error. So there is a gradual shift towards myopia. So postoperative refraction is based on the initial undercorrection that is made. There are two standard approaches. One is either you choose for an initial hyperopia or later emmetropia. In the initial hyperopia, the child requires to wear hypermetropic glasses and requires to comply for amblyopia therapy. We aim for emmetropia later in childhood. When we aim for initial emmetropia, the child develops myopia in later adulthood. We'll have to plan an IOL exchange or refractive surgery later on. So what is the process for us for biometry in these children? So initial, for us to calculate IOL power calculation, the first step is to do a proper biometry to calculate what is the IOL for the emmetropia. How much to undercorrect is the next step, which depends on multiple factors. So based on the age. So younger the age, younger the child gets operated, so we have to aim for a larger amount of hypermetropic correction. Laterality, again, bilateral cataracts, we can aim for a full amount of hypermetropic undercorrection so that equal refractive error is given for both the eye. Based on the vision, if child has already expected to have a dense amblyopia, if the vision is low, we would expect the child to comply very less for amblyopia therapy. So better for us to aim an undercorrection which would give lower amount of hyperopia or almost emmetropia. So child in the initial treatment years will comply better for amblyopia therapy. Later on, if the child develops myopia, late myopia can be managed later on. Then based on the fellow eye, so if the fellow eye is pseudophakic or fellow eye is phakic, based on the refractive status, we can plan for the undercorrection of the present operating eye. Then if the parents or sibling are high myope, again we can plan for a larger amount of hypermetropic residual refraction. So if in case the child moves into myopia, that would not be a larger extent of myopia. Finally, if the compliance to amblyopia therapy is doubtful, compliance to glasses, contact lens is doubtful, we can aim for lower hyperopia or almost emmetropia. Then finer adjustments can be made if there is a change in the site of fixation. If we choose for a ciliary sulcus, 1 to 2 diopter reduction based on the initial IOL power, we could decide. So we all know that axial length measurement either could be done with optical biometry, partial coherence interferometry method, lens star, or with IOL master, and ultrasound biometry traditionally by either a contact or an immersion method. I am playing a video just to demonstrate the techniques. So contact method needs to be done soon after the initiation of anesthesia, induction of anesthesia without eye speculum, and we should make sure that there is no indentation of the cornea, because falsely lower axial length could be made, and most of the errors happen with contact technique. EUA with immersion technique is the ideal method for calculation of axial length. So there is a probe that is placed and there is a coupling fluid between the tip and the cornea. IOL master is used for cooperative children as an office-based measurement. Manual keratometer could be used for cooperative children, more accurate. Handheld keratometers under EUA. Only thing, the problem is there is no fixation, so steady fixation, central fixation is not there. So we need to be careful about it. So repeated measurements are advisable, and the cornea should not be dry while measuring. There are other newer keratometers with autorefractometers handheld that are also available, which have good lighting, and it has melody functions in it, so that it could be easy for children to cooperate. Coming on to sensitivity of IOL power calculation to axial length and K reading. Shimoni et al., when they studied the axial length measurement between adult and children, they found for adults, for every millimeter error in the axial length, there is depicted 3 to 4 diopter error in the IOL power, whereas for children it is 4 to 14 diopter error in the IOL power. Trivedi et al., they studied the keratometry measurement errors and found that for every diopter error in the K reading, 0.8 to 1.3 diopter, there is an error in the IOL power. Mittelby-Haas, when they evaluated the error in keratometry in infants, they found that lack of fixation in children is the main reason for inaccuracy. So the deviation could be up to 6 diopter. The other studies, Benzion et al., when they compared the methods of biometry between immersion and contact, they found there was no significant difference in IOL prediction, whereas Garziu et al., they reported axial length measurements that were made through contact method were 0.24 to 0.32 millimeters lesser than what is done with immersion. So they recommended repeated measurements where there is 3 equal measurements with sharp retinal spikes. So instrumentation error in normal eye will result in 2.5 diopter for every millimeter error with the axial length, whereas for long eyes is 1.75, whereas you can see for the short eyes is 3.75 diopter. IOL power calculation, it's a controversial topic. There are no formulas that are proved accurate till date, and the arena of formulas that we have is SRK-T2, Hoffer-Q, Holiday 1, 2, and Pediatric IOL calculator. Theoretical formulas are more accurate for pediatric eyes. So which formula to choose? So various clinical studies have put forth. Miser et al., they studied 5 IOL calculations and they found none of them were satisfactory, and SRK2 proved fair to good agreement. Neely et al., they analyzed the IOL calculation errors and found newer theoretical IOL calculation formulas did not outperform older regression ones, and each formula demonstrated a high degree of variability. SRK2 had the least variable. Nihalani et al. Reported that Hoffer-Q was predictable with the pediatric small eyes. Epsheets et al., they found Holiday 1 and Hagees to be similar in IOL power prediction. SRK-T was comparable with Holiday 1 and Hagees. Cora et al., they concluded that all the formulas were less accurate in axial length of 22 and less. SRK formula had the best predictive error for compared to the SRK-T and Holiday formula. In 2016, published in Eye Journal, Vasavada et al., they performed a prospective study under 2 years of age, they reported SRK-T and Holiday 2 formula with best predictive error, and personalization of IOL constant did not affect the predictive error of the formula. So when we determine the target postoperative undercorrection, it should be a stepwise approach. We should consider the age and the projected growth of the eye. What is the ideal IOL power that has to be implanted? That should be one that can fight amblyopia, at the same time produce a least refractive error in childhood, anticipating myopic shift. There are various guidelines providing us how much to undercorrect. So Dahan's criteria, the most popular, 20% for less than 2 years and 10% from 2 to 8 years of age. The other table is based on the IOL axial length. There are various guidelines, Kennedy et al., Plager, Crouch, Trivedi and Wilson et al. They have also provided us the table, how much to plan. This is based on the age of the child, how much of target refraction. So in 2018, a study done from Bangkok by Lexcool et al. Published in Clinical Ophthalmology about the long-term outcome of intended undercorrection intraocular lens implantation in pediatric eyes. They had made a table of undercorrection based on the Gordon and Donzel's prediction on the axial length growth keratometry reading, starting from 6 months of age to 10 years of age. So in their study, they had found that out of 84 children in their eyes, in their study, 45 eyes were myopic, and the mean refraction was minus 2.26 diopter. They concluded that 5% more of increment needs to be added for each group so as to avoid late myopias. So we're sharing our experience with the Dahan's criteria, which was published. We looked into the long-term outcome in children operated for cataract with IOL less than 2 years of age. We had a 6-year follow-up. So we had 39 eyes with a 6-year follow-up, and we found that the mean spherical equivalent at the time of study was minus 1.02 diopters. Mean myopic shift was 5.91 diopters. We had 46% with final visual acuity of 0.47 logMAR 2060. And we had 3 eyes who had to undergo an IOL exchange for large myopic shift at 9 years of age. And a comparison, when we compared between 12 months and 13 to 24 months of age, we had a myopic shift and visual acuity, which was highly significant. So presently now we are following the guidelines of Trivedi and Wilson et al. So at present, the acceptable age for IOL power implantation has been reduced even as younger as 2 months of age. So the modified and current recommendation by AAO guidelines starts from less than 1.9 months of age, and 4 powers are given for target refraction, and later on till 14 years of age, a detailed table has been provided in the AAO guidelines. So how much to undercorrect? From the observation studies, what we see, Sachadev et al. In 2017 in American Journal of Ophthalmology, they had seen that most of the children achieved an acceptable final refractive error using the guidelines of Kennedy et al. There was a myopic shift that was seen higher in 0 to 2 years of age and least in 4 to 7 years of age. Jesman et al., they compared the SRK2 and the pediatric IOL calculator group. They found no statistical significant difference found in predictive error and accuracy of predictability of postoperative refraction between the 2 groups. IOL calculator is a new tool for us, but word of caution, there are very fewer studies that are present about the predictability and accuracy of IOL power calculator, and this present study also has a very small study group of 15 eyes only. So to conclude, so the IOL power that has to be placed that's very ideal for the child is that which fights amblyopia and that is least refractive error in adulthood. And it has to be a case-based customization when we choose. So there is no published table for IOL power selection, and all formulas are unsatisfactory. For shorter eyes, we could choose Hoffer Q, and SRK2 has least variable in the pediatric eyes. Despite our best efforts, some children will definitely, maybe later on, require an IOL exchange or refractive surgery. So IOL in very young children, we recommend a long-term follow-up to tackle myopic shift. Thank you so much.
Thank you, Sashikala. So if you have any questions on this topic, we can take now. Unilateral cataracts? Sashikala, would you want to answer? What about unilateral cataracts?
Based on the Trivedi itself, there's a separate table for the unilateral cataracts, so which has lesser amount of hypermetropic undercorrection compared to the bilateral cataracts. So we're following that.
For a 6-month-old, like how much do you, how much anisometropy?
So 10 diopter or more than that we can, 10 diopter or more we can go.
But then you have to keep in mind the anisometropy also. So 10, this is the new table. Otherwise, normally we would reduce about 6 diopters. Or then the different school of thoughts, like some prefer not to keep the anisometropia, they treat them for the age at that particular, and then later on, when the myopic shift occurs, then they plan for IOL exchange or contact lens. So the next speaker would be Dr. Sandra. She's also my colleague in the pediatric unit in Coimbatore Aravinda Hospital. She'll be talking about tackling trauma and posterior capsular and poor capsular support in pediatric cataract patients.
Good morning, and thanks for this opportunity. So I'll be talking today on tackling trauma and poor capsular support in pediatric cataract. Children, as you all know, are very prone to trauma, and mostly this trauma is accidental. They get injured with the rubber bands, needles, pencils, sticks, playing with others, and even during festivals like Diwali, when we do see a lot of traumatic cataract. So from Southeast Asia, the incidence of trauma in children and pediatric cataract is about 25 to 38%. And the most common etiology in our scenario is injury with a stick or thorn. And mostly these injuries are more common in boys as compared to girls. And oftentimes they are associated with other ocular comorbidities, like injury to other parts of the eye, like zonules or cornea, and vitreous hemorrhage, retinal detachment, etc. So as you can see, children love to play with crackers, and this is a time when we do see a lot of injuries. So types, they can be an open globe injury like this, when there is a corneal tear with a iris prolapse and traumatic cataract, or it can be a closed globe injury, blunt injuries causing traumatic cataract by the force. And in the third picture, you can see zonular dialysis with a cataract. So there are a lot of conditions where you need to make a lot of decisions here. One would be regarding the timing of surgery. So do you do this cataract at the same time as when the patient presents with the initial trauma, or do you wait? And cataract management along with the primary corneal tear repair, if there is a very big tear and if there is a rupture in the anterior capsule and prolapse of intraocular contents, then we need to take it up immediately. Otherwise, if the capsule is intact, we can take it up later also. And again, whether we need to implant the lens as a primary IOL implantation or as a secondary IOL implantation. Site of IOL, whether it is in the back or is in the sulcus. Other concurrent issues, like whether there is any injury, other injuries, vitreous hemorrhage, retinal detachment, etc. And medico-legal issues, because some of these can be having a medico-legal issue also. So one of the most common difficulties that we encounter is how to take the clear topography in the setting of a traumatic cataract. So if the Mayas are very clear, then we can go with a manual keratometry or an automated keratometry. But if the Mayas are distorted, then what to do? So if we can rely on an OBSCAN topography here, and if the OBSCAN, as you know, takes the central 3 millimeter keratometry reading, and that can be used for the calculation purposes. If the Mayas are very distorted, then even after waiting for quite some time, the eyes heal with scarring, and hence if the Mayas are very distorted, we can go with the standard keratometry of the other eye, although this setting is very rare. And do not forget about amblyopia, because between the initial corneal tear repair and your management of the corneal tear and the cataract, it can be months before the optical visual axis is clear. And so many of these kids are prone to amblyopia, especially in the age group of 0 to 10. So we need to keep that in mind. Otherwise, a good surgery can be a waste if we don't think of amblyopia. So now I'm going to show you certain difficult scenarios of pediatric cataract. So this is a patient who had a very small self-seed corneal tear, and you can see the total rupture in the anterior capsule here, almost like the Argentinian flag sign. So the cortical matter is being aspirated through the ruptured anterior capsule, following which I am doing enlarging the rhexis. All the cortical matter has to be aspirated before you implant the IOL, because otherwise the incidence of proliferation, reproliferation and posterior capsule opacity is very high. So now the bag is inflated with a viscoelastic, and usually because it is a very big rhexis here, a 3-piece lens is preferred, because in case there is these cases are prone to inflammation, and if the IOL is going to come out of the bag, then the single piece will not be very stable. And all cases of pediatric cataract, we need to put a suture to the tunnel up to the age of 15 years at least. So you can see the well-centered IOL here. This is a case where the corneal tear repair has been done previously, and you can see the cataract which is a posterior subcapsular type of cataract here. there is a lot of iris tissue damage and some iris tissue loss also at 1 to 2 o'clock position. And the rhexis in pediatric capsule is very elastic, and we need to be very careful while doing the rhexis, with usually done only with the help of forceps. It may not be able to complete with the needle alone. So since we have got a good rhexis here, a single piece lens is being placed inside the bag, but there is a lot of opacity in the visual axis because of the dense PCO. So here the IOL is being lifted, and then the PPC has been done with a vitrector because of the dense fibrosis, and at the end of surgery you can see that the visual axis is quite clear. So this patient has a blunt injury. You can see that there is no corneal tear, but there is a very intumescent lens here, and also you can see that between the 7 to 9 o'clock position there is zonular dialysis and an iris tissue loss. So after making a small rhexis, because of the intumescence, the cataract is being aspirated, and now you can see the area of zonular dialysis and iris tissue loss very clearly. So now a double rhexis is being performed to enlarge the size of this rhexis, and because there is area of zonular weakness, a CTR is being placed inside the bag, and that will give more of support when you are placing the lens. So this is non-paying patient, so we are placing a 3-piece lens, and it was an older child also. Following the placement of IOL in the bag, the iris tissue defect is repaired with the help of a Prolene suture, because since it is in the 7 to 9 o'clock position, there can be a lot of glare if we leave it just like that. So with the single pass 4th row pupilloplasty is done, and the pupil is reconstructed. This is a child who had a sclerocorneal tear repair done at 7 to 9 o'clock position, and that area where their initial injury has been there is a lot of synechia. So for better visualization, iris hooks are being used. I think you need to put the charger. So the iris hooks are being used for better visualization, and the cortical matter is being aspirated here, and the IOL is being placed inside the bag. So following this, by lifting the IOL, we are doing a small PPC here, because the age of the child being less, unless a PPC is done, the incidence of posterior capsule opacification is almost 100%, and then a generous anterior vitrectomy is being done, and the tunnel is being sutured. So this is a case who had a blunt injury with this was a cracker injury, and there was a lot of inflammation initially, and when the inflammation settled down, there is a very dense anterior capsular opacity. So this you cannot do a rhexis in this case. You have to cut over this anterior capsular opacity with the help of 1R scissors, and then the loose cortical tissue is being aspirated here. So after aspirating the cortex, you can see that the posterior capsule has been polished, and now the visual axis is quite clear. As far as possible, this membrane is being removed so that it doesn't come in the visual axis. And now you can see that it's very clear, and 3-piece lens is being placed here, and then dial inside the bag. So this was an older child, above the age of 10 years. So I have not done a posterior PPC in this case, and because also the anterior axis was not very good. So this patient has had a cataract aspiration along with the corneal tear done previously, and now is posted for secondary lens implantation. So the importance in secondary lens, you have to remember that always you should use a 3-piece IOL. You cannot implant a single piece IOL in the sulcus. Another thing is there can be a lot of synechia, and all the synechia has to be released before you place the IOL inside the bag, inside the sulcus, because otherwise within a few days there can be a pupil capture, and most of the IOL will be in the anterior chamber. So after reforming the sulcus, the IOL is being dialed inside carefully. There is a PPC already present, so just a vitrectomy, anterior vitrectomy is being done. And then in some cases, the visual axis can be it can be opaque. I think the laptop charger has to be connected. So any questions you have in the meantime by he connects the laptop till now? Yeah, we do inject steroid. I didn't show it in the video, but we do inject steroid, 0.5 cc. And also we can do under steroid cover if we feel there is going to be a lot of inflammation. We can give preoperatively also, we can start on injection IV Decadran. Usually in the uveitic cases we do do under a strong steroid cover. Yeah, Decadran. We use Decadran in our setting. Yeah, but okay. Thank you.
We also use intracameral moxifloxacin for all the pediatric patients. We give subconjunctival Decadran.
Subconjunctival, yes. So traumatic cataract, there can be a lot of surprises on table. So that's why you need to always be open to the, sometimes we may need to put an iris fixation, or we may think that there is enough support, but then we may need to do a scleral fixated or an iris fixated lens. So proper planning is essential. Sometimes the pupil may not dilate as well. So on table we may be having some difficulty in stabilizing the lens. And when we want to do keratometry, sometimes in a dense corneal scar, then we may not get a good K reading as such. But when we take the OBSCAN value, we can get the central 3 mm reading if the damage is peripheral. And then we can compare between our manual K reading and the OBSCAN K reading, and we can take a mean of the two and then decide on the lens power. The initial corneal tear repair we do like as soon as the patient comes in. Usually even if it is a Sunday, we prefer to take up the surgery on the same day and do it as far as possible. But regarding the IOL placement, it always depends. We should think, and if everything is okay, then we can place it at the same time. Mostly when the corneal tear is very small, then we can place an IOL at the same time. But if it is a larger corneal tear, then we can place it in a secondary setting, which is more safer with regard to the lens power calculation, and also the inflammation is very less. So if we place the lens at the same time as we are doing the surgery, then most often there can be a dense membrane also on top of the IOL, and we may need to take up the case again for membranectomy. So secondary lens implantation is better if there is a very severe injury to the eye. Yeah, we do. Mostly in all cases we do use Trypan blue. Not at all, not at all. I don't think Trypan blue increases the inflammation. Yeah, vitrectomy can be used only in very small babies. As like in any baby above the age of 6 months, using a vitrectomy to do the anterior lens, anterior excess, I wouldn't recommend, because yeah, then you have to operate only within the area of fibrosis. That area of fibrosis was not big enough that we can do the vitreous excess in that case. If the fibrosis is very large over the entire anterior lens capsule, maybe yes.
Because it gives a very round, you can take a very round, clean rhexis with a vitreous, though not as good as a manual rhexis.
True.
In particularly traumatic cases with fibrotic capsules.
Yeah, but that case was it was not central, it was a little eccentric. So if you do only in that area, then the visual axis, there will be that area of fibrosis again coming and hampering visualization. So when we are
doing... No,
doing...
I'm telling you about the anterior capsule.
Yes, anterior capsule,
yes,
yeah.
anterior capsulotomy.
Yes, because that was not exactly in the center, that was a little off-center.
What is your start of reverse age?
I'm sorry, sir, I'm not able to hear.
regarding the scleral fixated lenses, what is your lowest cutoff
Regarding
limit? SFIOLs.
SFIOLs, I would say around 8 years of age will be the lower limit. Because below that, the scleral rigidity is not that good. So there is a lot of chance of getting postoperative hypotony. So I would prefer an age of 8 years for scleral fixated lenses. Yeah, I do.
इसको दवाइयो एडीएमएट दवा एडीएमएट दवा हो गया मैम आप क्या नहीं ये एक मिनट एक मिनट आप कर लीजिए कोई बात नहीं आ गया मैं नेक्स्ट
Excuse me. I just want to advance that. वीडियो में वो एडवांस कर दूँगा
ऑडियो
वो नहीं वो एडवांस कर
ये लास्ट है
हाँ लास्ट है उसमें तो मैंने आधा वीडियो ख़त्म हो गया एक्चुअली ओके अब से आप देखो ओके फाइन
एक मिनट क्या करना है
वो आधा वीडियो एडवांस करना है यही से प्ले करो
How many here in the audience do pediatric cataracts? What is the youngest age you prefer to put an IOL implantation? 2 years, sir. If it's unilateral cataract? More than 1 year. Anybody has a different opinion? IOL implantation, sir. And your follow-up of? You took the haptic. What type of lens was it? Okay. What type of lens did you put, sir? Okay.
Ma'am.
And what was the corneal diameter? Okay. And do you have a follow-up of, how long do you have follow-up, sir? And it's
I did posterior capsular rexis plus vitrectomy, and both eyes were good. It was associated with alternative convergent skin.
I see.
After 1 year, I had corrected the skin also.
Oh, okay. So you've done squint surgery as well.
Yeah, we can go, yeah.
Okay.
So this is the next case where temporal clear corneal approach is being used for secondary lens, because superiorly, as you can see, the corneal tear repair has been done and there is a lot of hazy media. So here the posterior capsule is fully intact, though there is a lot of synic A which I am releasing now, so to have the space to put the IOL inside. So after releasing the synic A, you can see the clear corneal incision is being made. And the white color opacity that you are seeing is the anterior capsule actually, and the posterior capsule is fully intact. But in this case, I was not able to separate these two layers, so I am going to place the 3-piece lens only in the sulcus. But in certain cases, if you are able to separate the two layers, then you can attempt implantation inside the bag also. And here, after filling the bag with the viscoelastic, 3-piece lens is being injected into the sulcus. And then following this, we need to do the posterior capsulotomy here, because the PC is fully intact and it already shows some minimal posterior capsule opacification. And if we leave it as such, then there will be a dense opacification within a month or so. So the size of the posterior axis should be around 3 to 4 millimeters in size at least. So we are making the initial nick and then enlarging it with the help of the forceps. So along with that, in our institute, we do the PPC and the anterior vitrectomy up to 10 years of age at least, because that ensures a good visual access, and IOC capsulotomy in very young children is not very easy to perform. So you can see the visual access is clear here. In case the corneal opacity is coming right over the visual area, you can do a small bit of optical iridectomy or a pupilloplasty also, so that the visual access is clear. So here again you can see the secondary lens being implanted. Most of the capsule is, posterior capsule is intact except at the site of the initial injury, where you can see that there is a dehiscence, and also there is a lot of opacification in the visual axis itself. So I am trying to release with the spatula, but since being unsuccessful, cutting it with the help of the Vanna scissor, because we need to form the sulcus in that area also, otherwise the pupil is going to get captured there. So after cutting the iris tissue with the Vannas, there is space for injecting the IOL there now, and hence then after all the synic A has been released, the IOL is being injected inside the you can inject it entirely into the anterior chamber also and then dilate into the sulcus, which is more easier. And then following this, that you can see this area of fibrosis which is coming right in the visual axis, and that area has to be cleared now. So after lifting the IOL, then you can see the membrane is very thick. So sometimes these membranes will not be able to cut with the vitrectomy, and then you have to go with the micro forceps or the Vanna's scissors, and then you have to enlarge that area of fibrosis. So now after cutting that, the visual axis is quite clear now. So the child's visual potential will be good. So here again you can see that there is an area of posterior rent, and I am not able to see how far the posterior capsule is, support is available in this case. So using iris hooks, then we found that the nasally for around 5 clock hours, the posterior capsular support is not there. So the capsule is present only inferiorly, temporally and superiorly, but nasally absent. So injecting the IOL with oriented vertically, so that the haptics are oriented vertically, and it will be stable. But even after dialing it vertically, sometimes it can rotate and then it can become unstable. So in such situations, it is better to put an iris fixation. So I'm doing an iris fixation here and using a proline suture, fixating the superior haptic to the iris, so that the lens will remain in that position and post-operatively will not rotate. So with the proline suture, that superior haptic is fixated to the iris, and now you can see that in the visual axis the IOL is centered. Again, this is a sclerocorneal tear repair with a very small pupil, and the iris hooks are being used mainly to do the posterior membrane has to be removed fully. And after injecting the IOL, we can also do the PPC and then inject the IOL, but in our institute we are used to doing it this way. And this membrane is very thick, so it has to be cut with the scissors and then enlarged with the help of the vitrectomy cutter, and at the end of surgery the visual axis is very clear. So iris hooks can be very useful, or any form of pupil dilating device is useful. In this case, last case, the PC support is totally not there, so scleral fixated lens is going to be done. So we are doing this scleral fixation with the help of two partial thickness scleral flaps, which are created nasally and temporally. And then the IOL is being taken out with a needle guided haptic insertion technique, where you can see that the inferior haptic is introduced into the hub of the needle, and then similarly the superior haptic is introduced into the hub of the needle and then externalized. And with the help of silicone stopper, you can fixate it for the time being, and then you can bury it inside the partial thickness scleral flaps. So this way the IOL is very stable, so you need not create the big scleral flaps as such. The partial thickness scleral tunnel is quite sufficient to tuck in the haptics, and the IOL is centered here. And following this, you can suture these two areas so that the post-op hypotony is not seen. Thank you. So I invite Dr. Kalpana Madam, who is our chief instructor, and she'll be talking on torics and multifocals in children.
Thank you, Sandra, and we're sorry for the delay with the audio visual problem. Are you going to fix it for me? Okay. So we've seen, we've been talking about the biometry in children and the other traumatic cataract secondary IOL implantations, and I'll be talking about multifocals and torics in children. We're dealing with a childhood cataract, a lot of therapeutic dilemmas, whether you should place an IOL or not. Like we were just talking now, discussing about what will be the ideal age. There is no ideal age. It's very different from individual surgeon. Based on the experience, they would prefer to place an IOL. Like the senior doctor there said that he would place a lens in a 4-month-old child, cutting the haptics. In a smaller eye, less than 10 millimeter of corneal diameter, then I would be a little skeptical in placing an IOL. So there's a lot of dilemma, and depending on the type of lens. Like in sulcus, we prefer a 3-piece lens. And the biometry we already discussed, we do not have an appropriate formula which is dedicated to pediatric cataracts yet. And then management of posterior capsule, again, is very important, which unlike in adults, there's a tendency of PC opacification. And the general senses would be to preferably put a monofocal acrylic lens. If it is in the bag, you can use a single piece, or if it is in the sulcus, a 3-piece lens. And usually you correct for distance. For near, you give them near vision glasses. And when you're treating children, you have to convince the parents or the caregivers. They always have these questions like, my child should be having a good vision for near, intermediate, and distance. He has to play different games, sports. and good binocular single vision stereo acuity is needed. And one thing they say that with my child be free from glasses. So you really have to sit with them, counsel them, and explain to them the need for glasses for these children even after the surgery. And coming to the premium lenses, the premium lenses do have a role in adult cataracts. In children, they are now, kind of picking up and guiding, getting a recognition in the pediatric age group. So again, we have a lot of, questions regarding how early to implant an IOL in a child, and then what type of advanced IOL technology you would use, and what is the role of multifocal accommodative IOL. Of course, has not been proven, and it's not advisable to do it in children because it's not very popular in adults as well. And then role of refractive surgery to fix the residual refractive error. So why multifocals? Like unlike in adults who are usually under the age group, presbyopic age group, so they already have lost their accommodation, whereas in children, sometimes this lack of accommodation can lead to abnormal visual development, which affects the stereopsis and binocular vision development. So when you advise a multifocal IOL in a child, there are certain requirements. Usually you prefer to do it in an older child, usually above the age of 8 years, and you need precise biometric measurements, precise IOL power calculations, and always aim at emmetropia or a small residual hyperopia of 0.25 or 0.5 diopters, and not usually more than that, then you will not have good results. And the patient selection, so do not do it in a very young child because you will have difficulty in predicting the growth of the eyeball, and you always undercorrect. We already seen in the biometry that undercorrect, keeping the myopic shift in mind, and always aim for a final refraction in adulthood. This is a video. This was a 10-year-old boy, Dinesh, who came with the intumescent lens, and we planned for a multifocal. I used the Varion guiding system for the centration of the capsular rexus. This was an intumescent cataract. Do you have a pointer here? So you can see as well, we are trying to do a smaller rexus and try to clean the cortical matter. It's better to debulk and do it, otherwise sometimes the rexus can get extended. So keeping the Varion, for the centration, I'm extending, doing a secondary capsular rexus. You have to be very gentle. And there was a question regarding trypan blue inducing inflammation. We haven't seen any inflammation with trypan blue. So do a thorough cortical cleanup, which is very, very important in children, because if you leave something, then there might be a chance of proliferation and then after cataract. And especially when you do a multifocal lens, the centration is very important. You can see, and I still felt that sometimes when you leave the rexus, it can cause capsular phimosis and fibrosis. So have an adequate size rexus. And I'm trying to clean up the viscoelastics behind the lens. And I thought it's better to do because definitely this child will develop a posterior capsular opacification. So I'm doing a primary posterior capsular rexus. Make a small nick. Use your ureters and then try to, you can see the posterior rexus here. And we always prefer to put a suture, especially when you disturb the posterior capsule. Here the vitrectomy was not done because it was an older child, so we could always wait and watch. What are the merits? Rapid visual rehabilitation for both near, intermediate, and distance, and this will definitely improve the chance of binocularity in these children. And because there is the loss of accommodation is less, there is a reduced risk of amblyopia in these children, and there's also near vision is better in these children. And there is an expanded focal range to include intermediate distance as well when you use a multifocal lens. And then elimination for need for bifocals in these children, especially when children, you deal with children little delayed who are not able to wear glasses. And then proper image focus in patients, like I explained, who are not able to wear glasses. The demerits with multifocal lenses, again, IOL power calculation predictability. So if you're dealing with children who are not cooperative and you're not having predictable results, and then it's better to defer placing a multifocal lens. Precise biometry, refractive stability is very important, so you cannot place a lens in a very young child. And visual development, because children do not complain. So, you really do not know how comfortable they are. So that is one thing that you can sometimes hinder the non-optimum optic and hinder the visual development in these children. And then you will have centration issues, like, and post-operative complications sometimes can cause decentration of these lenses. And then possibility of dense amblyopia in unilateral cataracts. Unlike in adults who complained of glare and halos and loss of contrast sensitivity, children fairly do not complain much. So they usually withhold and they don't complain about the symptoms. So you should actually keep in mind about this. And sometimes the defocus image may lead to continued ocular dominance and create problems in children. And intraoperatively, you have other challenges, like you saw this particular patient. So you have to be very cautious in doing the rexus, because adequate centration is very important. There might be positive pressure you have to deal with. So, and then if you are doing in younger children, posterior capsular rexus is very important. And if you're not, an expert in the technique, then sometimes you can treat to runaway rexus, and you may have to, defer the procedure. The other challenges, like we were talking about posterior centration, posterior capsular pacification, like this patient who had a repeated capsulotomy with lens pitting. So all this should be kept in mind before you choose to do a multifocal lens in a child. These are all the studies which have been done. This is a little older study, but this was done with an array lens with Jacobi et al. And their group, they said that 35 eyes are 26 pediatric age group. And then in this study, they've shown that at least 10 of them required an IOL exchange. And at least 16 of them required a repeat membranectomy. So not very convincing. And Cristobal et al. Came out with another study with multifocal for unilateral cataracts in children. But there are certain, the participants were 5 children between the age group of 4 and 6 years. But then there were certain limitations in this group where there was no control group, and the minimum follow was only about 21 months. So we do not know the long-term results. So, to conclude, multifocal lenses definitely is a good choice when you choose the right patient in an older child. But there are certain concerns, like, there can be a refractive shift. There is a potential chance of degradation of amblyopia due to loss of contrast sensitivity. And then multifocal can definitely be an option for older children. And then you need further studies. But there are some studies also, I think, from PGI Chandigarh. And coming to the next talk is the toric IOLs in children. So we all know that naturally when a child is born, it has against the rule of astigmatism, which outgrows, and by the age of 4 years, they usually become neutral or become, with the rule of astigmatism. And again, when you become old, going for the against rule of astigmatism. So torics in children with cataract, it is very safe and effective way to correct the preoperative astigmatism, and it gives a better unaided visual acuity and reduces the risk of amblyopia. This was a study which was done in Japan with Watanabe et al., and they said that 65.7% of kids with cataract have astigmatism, and out of which almost 83% was with the rule astigmatism, and 5.1 was against rule astigmatism, and 11.1 was oblique astigmatism. So the indications would be usually children, older children above the age of 8 years, if they have astigmatism more than 1.5 diopters, and always prefer to exclude children with subluxation, big corneal scar, or any other keratoconus or any macular pathology. The investigations would be a corneal topography to rule out subclinical keratoconus, always measure the corneal thickness, and you have to routinely follow these children for any keratometric cylinder. And coming to the procedure itself, the toric marking should be done before the induction of anesthesia, because it is better to do it in the upright position and using a topical anesthetic drops. Try to make the child understand and do the toric marking. So this is a video of a child with a toric implantation. Okay. So here you can see again I'm using the Varion. You can have a Varion measurement done for these children. I could see the capsule well, so I'm not using the, the dye to stain the anterior capsule. You have to be very gentle because you need a good, well-centered rexus. Doing a good cortical cleanup again is mandatory. So the axis was 92. you see that the lens is placed in the axis. So I decided to do a posterior capsular rhexis. Again, gentle to do a good centered rhexis, followed by vitrectomy. You can see the well-centered rhexis and the lens is in position. And this child is almost followed up for 6 months and the lens is very well-centered. There was also a study done in Russia, a group of toric lens, and I think it's Maria Uge, something like that, I'm not getting the name. And she has said that initial few cases she has done a posterior rhexis, but now she's deferred because of the decentration. She prefers to put the lens, and then later on, after 6 months or 1 year, if there's a PC opacification, you can take in for a plasplanar vitrectomy later on. So to conclude, toric IOLs can be a choice of procedure in older children because it definitely reduces the postoperative astigmatism and increase the uncorrected visual outcome. So, yes, multifocals and torics do have a place in pediatric cataract management, but the choosing the right patient is very important, and how comfortable you are with the procedure and proper counseling of the patient. Because when you do a premium lens, their expectation is much more, and then you would have sometimes problem, and keeping their living years in mind, you cannot do something which is especially when you're dealing with children who cannot come for follow-up. It's always better to do a monofocal with a good primary posterior capsulotomy and give them glasses rather than doing a premium lens and creating more trouble for the child. Thank you.
Next, I would invite Dr. Fatima, who is a consultant pediatric ophthalmologist from our Arvind Eye Hospital, Tirunelveli, and she'll be talking about rings, hooks, segments, and iris fixation in pediatric cataract.
Good morning, everyone. I like to thank Dr. Kalpana ma'am, Dr. Sandra, and the AIOC Scientific Committee for this opportunity. Apart from our routine cases, we do see cases of uveitis, Marfan syndrome, homocystinuria, and many more such complicated cases in our clinic. So in such situation, if we do lensectomy, if we do lensectomy and provide aphakic glasses, we end up with facing numerous drawbacks. And also the major concern is, major cosmetic concern is the eye appearing big through the glasses is a major cosmetic concern for the parents as well as the patients. And also, as Kalpana ma'am mentioned, we are in the era where patients demand to have free from glasses, so better to avoid this situation. If we opt a contact lens, again we have to face the problem of allergy, infection, and fear of handling. So how to tackle? We have many rescuers, and we will see 4 among them. First one is capsular tension ring. It is an open compressible PMMA ring with a rounded eyelet at each end. And if we see the history, in 1991, Hara and co-worker came out with closed equator ring. Thereafter, Nagamoto came out with a capsular bag support open ring. Then emerged the now the present day CTR, that is open PMMA ring with eyelets on either free end. Then came modified CTR by Sioni and co-workers, and in 2002 it is CTS devised by Ahmed. So what is the mechanism? The diameter of the CTR is larger than that of the capsular bag, so the centrifugal force inherent within the ring expands the capsular equator. It supports the area of weak zonules. It recruit and redistribute the tension from existing zonules and stabilize the entire zonular apparatus. It causes contraction and tautens the posterior capsule and reduces capsular phimosis and posterior capsule opacification. The indications of CTR would be mild to moderate zonular weakness, either localized or generalized. Generalized usually would be accompanied by with CTS, we will see later. And contraindication, if there is anterior capsular tear or posterior capsular rupture, non-continuous capsular rhexis, or severe zonular weakness, we should avoid trying CTR placement. Size of the CTR is chosen is based on the capsular bag dimension. Capsular bag dimension positively correlates with the axial length. So the available sizes, that is 10 millimeter compressed diameter and 12 millimeter open diameter is suitable for microphthalmus, and 11 for normal axial length and 12 for myopia. Timing, any time after completion of capsular rhexis, we can introduce CTR. Insertion technique, we can insert CTR by injector or manual. Here is a video showing. I got this from my head of the department, Dr. Meenakshi. Here, where it's a traumatic cataract with 3 clock hour zonular dialysis. After vitrectomy, CTR is being slided into the bag gently along the curvature of the bag, and the terminal end is taken with the help of Hoagland's hook, with the help of McPherson forceps. Placing the terminal end is the crucial part in placing the CTR in the bag. We have to constantly monitor whether the CTR goes inside the bag when we introduce the terminal end of the CTR. If we place a CTR before cortex was, we have to face some difficulty because the cortex is sandwiched between the ring and the capsular bag. Then removal should be done in a tangential manner, and it should be started from the area where the islets are present. Points to remember: the site of introduction would be easier if we opt to introduce the CTR opposite to the dialysis site. And the complications, we should remember that CTR can slip into sulcus, angle of anterior chamber, vitreous cavity, posterior capsular rupture can happen, and rarely fracture of CTR can happen. Overlap of the end terminals is needed to provide complete circumferential support. Coming to modified capsular tension ring, it is same like CTR, and it has a hook-like filament attached to it. And this has an eyelet at the end, which has an offset of 0.1 millimeter, which helps it to sit over the anterior capsule and help for scleral fixation. And the types, if you see, there are right and left model where the ring, the filament is attached. Filament is attached to right side or left side of the ring, and there are double loop model as well. Sizes same way like CTR. Indication more than 180 degrees zonular dialysis and marked lens decentration. Timing same. Coming to a video of Sioni CTR. It's a nasal subluxation of right eye in a child. Here, sclerocorneal tunnel is being made because considering the low ocular rigidity in the child age group, and capsule is being stained with trypan blue, and rhexis is being initiated. Care should be given to avoid extension of rhexis, because this is the crucial step. If we lose this step, we cannot think about placing sioneering or CTR into the bag. So we have to do it patiently with high molecular weight viscoelastics. Repeated injections can be done so that we will maintain the chamber and after making rhexis, hydrodissection is being done. Since it is ectopia lentis and clear lens, it is being aspirated with Simcoe cannula. And corresponding to midway of this zonular dialysis, this sclerocorneal pocket is being made. Not working. Laser light. And a straight needle of long straight needle of proline suture is being passed through that reverse scleral pocket and emerged out through main tunnel, and that needle is being threaded into the Sioni capsular tension ring, and the same needle is reversed and taken back through scleral pocket. Here are two cases. Here are two cases of similar nasal subluxation. Just wanted to show we can place either Sioni R model or L model for same kind of subluxation. Only thing we have to keep in mind is the method of insertion and which end we are taking first. In this first case, we are taking the end closer to the loop first, and the plain end is the trailing end. In the second case, since we have chosen this model, this end will go first, and this end close to the loop will be the trailing end. Sorry. Then the sutures are retrieved and retrieved out from the scleral pocket and sutured. I'm sorry, it is on. And the points not to forget is the correct orientation of the ring has to be maintained, because if we flip the Sioni CTR, the offset will go posterior, then it would be difficult. And sutures preferred here are 9O proline or 8O Gore-Tex, and suture tightness should be optimum and well buried in the scleral pocket. Coming to hooks, iris hooks are flexible polypropylene hooks with silicone stopper. It is definitely used first to provide large stable pupil size. Usually in pediatric cataract, since the cataract is soft, usually we can manage with small people, but some occasions CVAT cataract, very small people, we can definitely use iris hooks. Since the introduction of iris hooks require very less than 1 millimeter incision, we don't suture after removing it. And also it can be used to transfer to anterior capsularum, like that I showed in the previous video, to stabilize the capsular bag. There are special capsular bags devised for that purpose by Macul with an angulation here, and so that it will not tear the capsule, and also it has a blunt end. It is safe to use to hold the capsule. And the Hoagland hook is used to expand the pupil size. 2 Hoagland hooks are used to do stretch pupilloplasty and also to break adhesion of iris and capsularum in case of secondary IOL placement. Coming to Ahmed capsular tension segment, this device is also made of PMMA, a partial ring with a 5 millimeter radius of curvature spanning 90 degrees with a raised single eyelet centrally, which is designed to sit anterior to the anterior capsule. So the benefits here are we can use one or more CTS based upon the need, and it can be placed anytime after capsular access, and also it can be placed even in the presence of anterior capsular tear or small posterior capsular rent. And also it can be used for intraoperative supportive device like using inverted iris retractor. It can be placed while doing phaco or cortex was, you can support the bag intraoperatively. This is a video showing capsular tension segment placement. Here it's a microspirophakic eye where the phaco part was done by my senior Dr. Mahideen. He did a wonderful phaco and placed CTR, and to avoid pseudophacodonosis, we plan to do this CTS placement. Here we are doing, since because it's a post-trab case, we don't want to handle the conjunctiva, we did Hoffman pocket from the clear cornea. And this is the second Hoffman pocket is being made, and the edge of the Hoffman pocket is being marked with the marker, and the needle is passed from the main tunnel into the Hoffman pocket using a bent 26 gauge needle. Then it is being threaded into the CTS. And again the needle is taken back through the Hoffman pocket. Since CTS has many dialing holes, it is easier to dial it inside the bag. After dialing it inside the bag, the sutures are retrieved out from the Hoffman pocket and sutures are tied together. Similarly, to place CTS in this Hoffman pocket, we are just retrieving the needle out of opposite paracentesis for easier passage into that pocket. The needle is being threaded into the 26 gauge cannula and taken out. Again, after threading into CTS, the second needle of double arm proline suture. Stopped. Video is. So I cannot go to the mid. It's already half. Okay. Anyway, the CTS like the previous one, the second one was fixated. And coming to iris fixation with suture, there are two methods based upon the iris, the suture through and through iris when it is passed. That is, if it is passed after IOL placement, that is one method, optic capturing technique. And one more type of technique is before IOL placement, we can pass through and through iris suture. And types of suture tying is seeps or slip knot or modified mecanal technique. Dr. Chang has reported a few cases of seeps or slip knot where he has studied, where he has given good result with this knot. Here this is done using the suture is passed through and through iris, and this distal portion is taken out through paracentesis out, and this free end is looped into this distal portion, and then when this free end and this free end are pulled apart, the suture will go and straight away lie over the place where we want to make be the suture. So it is the knot that can be tied externally and then slid through a paracentesis opening to reach over the haptic without any need to displace the IOL. And there is another method, the modified mecanal technique. It is simple, straightforward, where the suture is tied through the paracentesis made closer to the iris bite. This is a video demonstrating seeps or knot as well as mecanal technique of tying. Here the lens is already there, but it is decentered, so two paracentesis is being made. Since IOL is inside, we can manage with just two paracentesis. We have to bring the optic to the iris plane and capture it over the iris, over the pupil, optic capturing technique. After capturing the optic, then we can pass the long curved needle of proline suture through and through iris, including the haptic. In the right side, it is just, the needle is just being retrieved through and through cornea near the limbus. The left side, as a seeps or knot was planned, the suture is after passing through and through, the suture is being retrieved through the paracentesis. To do seeps or slip knot, we have to retrieve the suture through paracentesis. Otherwise, it's not possible. Then the captured optic is positioned behind the iris. Now the distal portion, as I already mentioned, the distal portion of the suture is brought out through paracentesis. And to that, this free end is being looped. And now both the free ends are, when they are pulled apart, the suture nicely, it will go and sit where we want. that movement of the IOL says this is holding the iris. We can repeat the same step 2-3 times, and this side it is by mechanical technique, where the sutures are retrieved out through paracentesis made closer to the iris bite. It's time. Okay, now just we have to retrieve the suture out and suture it and tie it together. We'll move on to the only few more slides, 2-3 slides. This is published by my respected teacher, Dr. Haripriya, where he has described a technique of here he places the suture through and through and retrieve and take out the loop outside, and now after taking the loop, he ties the haptic to the loop and places inside, and same way the IOL is sutured. Oh sorry, video will come. Just I will show up to the looping of the IOL, how we retrieve the suture out, and okay, madam. That's all. This is the way we are taking out the suture out, and as I shown in the diagram, it will be placed. And complications such as iridodialysis, pupillar distortion can happen. So to conclude, rings, hooks, segments, and iris fixation technique help to maintain long-term centered IOL. But apart from surgeon skill, good patience, good assistance, and good anesthesia are important for successful outcome. I acknowledge my teachers and guides, anesthetists, OT staffs, and Aravind Hospital, Tirunelveli. Thank you. Thank you for all the patient listening.
In Aravind Eye Hospital, Coimbatore, Dr. Amrita, who will be summing up finally with a follow-up and rehabilitation, which is recommended for the pediatric cataract.
Very good morning, everybody. So I'll be talking about the visual rehabilitation after pediatric cataract surgery. So thank you, madam, for this opportunity. What next after pediatric cataract surgery? Yes, of course, it's a very long run. Surgery is just the first step in visual rehabilitation. So there are various factors which affects the visual outcome after surgery. So lens status, that is whether it's a unilateral or a bilateral cataract, laterality, lens status, whether we leave the child aphakic or with the pseudophakia. Of course, age, earlier the age, better is the visual outcome. Amblyopia is a major factor. Again, there are socioeconomic factors and systemic factors. So the IATS study says that placing an IOL below 7 months of age is associated with increased risk of glaucoma, and there are added surgeries compared to contact lens group. But this is way back in 2010. A lot of advances have happened over the past 9 years. So we have safer anesthesias where we can take up younger children with the safe anesthesia. And there are better instrumentations. We have safer, more biocompatible IOLs. We have better OVDs which helps in manipulation easier. And we have better vitrectomy with better cutter rates. So all this has made placing an early IOL more successful compared to what was it before. So there are some benefits of placing an early IOL. There is a lesser risk of amblyopia. So with better instrumentation, we have less postoperative inflammation as compared to earlier. And also there is early recovery. We can see the picture shows a 6-month child which was operated just the day before we came here. We can see a white and a white eye operated by madam. So of course, it is not without the risk. There is an increased risk of glaucoma. There is increased incidence of visual axis opacification, and there is a possibility of resurgeries. Hence, careful selection of cases is very important. So primary IOL implantation below 1 year of age is not safe in these cases like microphthalmia, microcornea, PHPV, any anterior segment dysgenesis, and associated systemic disorders. So once IOL has been placed, we have to correct the residual hypermetropia with the appropriate correction. Glasses can be provided in the immediate post-operative period or after 2 weeks. So usually we give a near vision aid after 2 years of age. So spectacles, there are a lot of spectacle frames available which are more durable, more soft and elastic. So whenever feasible, we should include the child in decision making. So comfort coil type, as it is shown in the figure, it's more comfortable in the toddlers. Frames with the holding straps is comfortable in infants. So near vision aid can be given either in a cryptoc bifocal form or an executive form. So whenever we leave the child aphakic, contact lens is a preferred way. It's more convenient for unilateral aphakias because it gives a better binocular vision and stereopsis. We can use either an RGP lens or a soft extended wear contact lenses. Of course, contact lens is not without risk. So we have to always choose the patients, the right patients. You should sit with the parents, discuss the pros and cons, and you should ensure that the patients come for a regular follow-up. So whenever we are planning to give spectacles in aphakia, it is easier way to handle. There are multi-drop lenses which are available, which has a central spherical zone, which flattens into an aspheric zone, which blends to a ring of no power. So the drawbacks of glasses, as we all know, it's a heavy lenses, cosmesis is a major issue. There is a problem of restricted field and anisoconia. So it is not recommended in anisometropia more than 3 diopters and more than 1.5 diopters of cylinder, and it is not more comfortable in children with nystagmus. So amblyopia, definitely it's the major thing which has to be dealt in rehabilitation. So major success depends on the timely management of amblyopia. So it's a stimulus deprivation type, and it is more common in unilateral cataracts. So whenever we are planning a bilateral surgery, the second eye should be operated within a month's time. In our center, usually we operate in a gap of 2 weeks. So occlusion, start occlusion as early as possible. So duration depends on age and severity of amblyopia. In infants, we usually follow 1 hour per day per age. That is, if a child is a 4-month-old child, patch the better eye for 4 hours per day. So after 6 months of age, it is usually 50% of the waking hours. So continue occlusion till age of 8 and taper the occlusion duration before stopping it. So follow-up, usually 3 monthly follow-up up to 2 years of age, 6 monthly up to 5 years of age, and thereafter it's yearly. So during each visit, we have to check the visual acuity, refraction, slit lamp examination to look for the centration of the IOL, any visual axis opacification, intraocular pressure measurement, axial length, indirect ophthalmoscopy, ocular alignment, and amblyopia. So glaucoma, it's a major thing which has to be seen during each visit. We have seen children developing glaucoma even after 10 years of surgery. So glaucoma can happen because of surgical manipulation, because of the post-operative inflammations, use of post-operative steroids which can cause a steroid-induced glaucoma, and any associated anatomical changes which can be associated with cataract can also lead to glaucomas. So whenever you see a child during follow-up, if you notice a rapid axial length elongation, frequent change of refraction, and frequent and progressive myopia, always keep in mind of glaucoma, because children will not present as adults with cupping and restricted field. These are the first things which we see. So these things has to be kept whenever you are measuring an intraocular pressure, because when you leave the child aphakic, it is proven that aphakic children have an increased corneal thickness which can give a false high IOP. And while measuring through non-contact technique, the child might squeeze the eye. So there is always a possibility of false high IOP. And whenever you are planning an EUA, always measure the IOP soon after the induction. So planning of secondary IOL age, yeah, it differs. Every people have their own ideas. In our institute, we usually plan secondary IOL at 5 to 6 years of age. So if it is a unilateral aphakia, we plan it much earlier. So secondary IOL can be planned with, can be combined with strabismus correction. So whenever there is an adequate PC support, we can go for an in-the-bag IOL if it is possible to separate the anterior and posterior leaflets using a micro scissors. We can separate it and we can plan a in-the-bag placement of IOL. If there is, if it is not possible, we can place a 3-piece foldable IOL in the sulcus. If there is an inadequate PC support, we can either plan iris fixation if there is a minimal PC support, and if there is absolutely no PC, we can go for a scleral fixated IOL. So myopic shift is a problem whenever there is an inadequate undercorrection during the primary surgery, or sometimes if we have planned for an emmetropia during the surgery. So any child associated with glaucoma or amblyopia can have a rapid elongation of the axial length, which can cause a myopic shift. So initially you correct them with glasses or contact lenses, and IOL exchange surgery or refractive surgery can be planned later when the myopia stabilizes. So visual axis opacification is a common problem what we see. Incidence is inversely proportional to the age. Incidence is almost 100% if the PC is left intact below 4 years of age. So in the bag placement of a foldable hydrophobic acrylic lens is safer, which can prevent visual axis opacification. Of course, as madam told, good cortical cleanup is a very important thing to be done during the surgery. So whenever we see a proliferative PCO in an older child who is cooperative enough, we can plan for an IAOC capsulotomy. If it is a young child, or if it is a PCO is of fibrous variety, or if a child has a nystagmus or a mentally retarded child, we have to plan for a surgical membranectomy. So to conclude, early detection of the cataract, appropriate management, a timely follow-up, and appropriate management of the complication leads to a happy child, happy parents, and of course a happy doctor. Thank you.
Thank you, Amrita. Actually, just few more points to add is the femtosecond laser in pediatric cataract. You've seen that a lot of discussions going on, but then it's not really indicated. It's very difficult to put the child to sleep, take the child, do the, the rexus, and of course only for the rexus you have to take the child and the incisions, and then bring back cells. So it is not really, a good technology to adapt in a pediatric cataract. And of course the Zepto for the rexus can be a good choice. So we've tried to cover, what is newly being adapted in pediatric cataract, but then it's again very important to choose the right patient and customize the procedure which is right for that child, for that age, and not do something very fancy or something which is new in the market. So that is one thing I would, request as a carry-home message. Thank you. Any questions? Maybe one or two we can take. Okay, thank you.